So warm welcome to everybody joining today to this PD-L1 SP142 in triple negative breast cancer case review session by Dr. Simona Costache and Dr. Corrado. So it's open for discussion. We will look at the result of your scores, let's say, and we'll have discussion, and feel very welcome either to speak up or to write in the chat, and together with the team we will monitor the chat. So hand over to you, Simona and Corrado.
Thank you very much. We'll keep it very brief because I think we've had a look at the data and they look very nice, very good. So relatively little to discuss, and also I can see that there aren't a huge number of people online. So it's really nice if you unmute yourself and we can have a chat about things if you want to add and make a comment. So please do. Okay, so this is the first case, and just to remind those that are not used to it, that we had asked you to put it in boxes, either below threshold or above threshold for positivity, in this case triple negative, and then if you think it's non-evaluable, say so. And then you have this panel diagnosis that doesn't really mean anything. It means that 3 or 4 people with experience in reporting these cases have looked at it, and this is their opinion, and whether they all agree will be 100%, and if they don't agree, there will be a percentage of that. So this case seems uncontroversial. Everybody thought it was positive. The panel also thought it was positive. We can have a quick look at it. Is this the one we said we were surprised that everybody agreed?
No. That was okay. The other one, the second one, I think.
This is the one, no?
I must confess that even these, for me, even excisions are a little bit more tricky.
Okay, so this is the one we are talking about. So this is clearly some DCS at the edges, and a bit doubtful whether this is invasive or not. Yeah, it is invasive.
No, it is invasive.
And then this is kind of the mass. There is a bit of a hole here and here. This will be the cavity of the marker clip with multinucleated giant cells. Okay, fantastic. And this tumor seems to be rich in inflammatory cells, in immune cells. Cool. PD-L1 and the usual search for, these are our controls. Seems to be working. And there is an annotation. I think I put this annotation here.
The annotation.
Okay, I put this annotation here because I was trying to work out what is our 1% area. So I kind of, roughly speaking, I encircled the whole area, got the area of it, and then I made a smaller circle, which is our target. If we can fill up this area, then we are up and running. And you can see at low power, this 142 is nice because at low power you see many things, not all of them, but many things, especially if they're in groups. Obviously, as you zoom in, you see a little bit more. Make sure it's not tumor cells. That's good.
Make sure it's not pigment.
Make sure it's not pigment. And already you can see that there is quite a lot here, in referral to our target area. There is quite a lot here, and then there are more areas scattered about.
Yeah.
So I thought this was a difficult case.
Yeah, me too. So the 2 positive cases, which I think we both in the end scored positive, but I was a little bit surprised when I've seen the overall diagnosis,
100%.
And how people scored them, like not even one scored it negative. With this one, I was more confident to call it positive, although not very high. I don't know. More than 2%, I don't think it was. So it was 1 point something.
Yes.
So
really, actually, well done, everybody.
Yes.
No? Excellent.
Just pay attention, because yes.
Yeah, I think this was very good, and you can see this zoning. Is not throughout the circumference. This is mostly at the edge of the tumor, the periphery of the tumor. This would be that kind of immuno-excluded type of pattern in a way, because when you zoom in the center, it's desert.
Negative. Exactly.
Yeah, for PD-L1. And okay, so this was a nice case. I don't know if anybody has any comments about this, but yeah. It's kind of good. You can see that if we had a core biopsy from this tumor, most likely we would have hit a negative area and call it negative.
Yes.
So that's the value of repeating any negative core biopsy on larger pieces of
Excision.
tissue. Okay,
Indeed.
so that was great. And case number 2, 100%.
This was more controversial even.
Was it more controversial?
This one, to be honest, I was very much, if I would call this positive or negative.
Okay.
On balance, in the end, I thought, yes, it is positive, but the positivity literally was 1%. From my point of view, in my eyes, I think it's the next
So
one.
142,
No,
this one,
it's the next
is that
one.
not this one?
I think it's 39.
142, yes, you're right.
39.
Okay, so that's the core biopsy, so there is only one bit of tumor here. Probably because remember, this is not about carcinoma cells, it's about area, tumor area. And so all of this is invasive tumor area, even the sclerosed bit. So that's the area. And I think I might have done the same because I was terribly anxious that I didn't really understand this case very well. So this is my target area here. Here there is much less. I can see some bits here and here and here. But I think as we fill up the screen a little bit more, actually you realize that's the target. Actually you realize that there is already quite a lot here that we might have filled 2/3 of that rectangle, and there is more. Yeah. And then there is more. So
it's not that much more.
Not that much more. Again,
That's
it's a tight 1%, but it's positive.
Yes.
Yeah.
I'll still stand by the decision that it is positive, but you need to be a little bit cautious when you score this.
And also the other thing is that by visual impression, the amount of area occupied by brown is relatively small. But remember that this brown cell has got a bigger area that is not brown, and we need to consider the area of the whole cell rather than just the brown bit. And so, yes, I think probably that's a good filling of this rectangle.
And again, how I sorted out both of these cases that, from my point of view, are a little bit controversial because it wasn't like a positive, I can close my eyes, it's positive. Take it field by field and put a magnification that you are comfortable with, 20 or something, and see in each field how much percentage would you give. And in the end, just sum up those percentages and divide it of how many fields you counted. And you'll have a more accurate, a little bit.
I think I saw you with a piece of paper with this case doing these things.
Not everyone, and I know this, not everyone has digital pathology. For us, a little bit, it's more easier, like Corrado has done. You can see the area, then divide it, see how much you need to fill it. It's a little bit easier. But we are with the slides under the microscope. So even this with field by field, you can do it with the microscope. So I think it's a useful trick.
So I wanted to ask you, Simona, something about this staining, because these are clearly huge nuclei. So this we must be near. This must be carcinoma here. But what are we staining carcinoma cells, or what are these blobs of staining? Do you think this is tumor cell staining?
It might be, but not entirely. I don't think it's entirely. I've seen tumor cell staining, and you do have a nice membrane staining, even with 142. Usually when you have these blobs still, there are immune cells in between.
Yes, I think you're right. So probably these are infiltrating macrophages, and they have cytoplasm everywhere, although the nucleus may be far away. Their cytoplasm goes everywhere. So probably we are staining granules within the cytoplasm macrophages. Okay, that's cool. Right. So
maybe that's a very good point. Maybe next time we should. I think we have few, not that many cases where with breast that we got staining with tumor cells. It's more frequent in lung, when we also have for atezolizumab, but very rare also in breast. So it will be interesting.
Okay. We have some questions.
Case 2 has a comment. This core case 2 has so much lymphoid infiltrate. Is it primary?
Good question. I think he was, but let's have a look at the. I don't know, because
that's skin.
Skin. doesn't
So
tell us very much.
it might be primary, yeah.
I think
Usually because
probably.
when it is breast and they are just making the punch biopsy, I don't.
There's a kind of, no, these are not lymphoid follicles. These are,
Yeah,
no,
I think
it's
it's
probably
primary.
primary, yes. Yeah.
That's a good point.
Okay, so we go to next case, which was 3. I think he was here. And another less than 1%, or in fact, maybe no staining whatsoever.
Yes.
Sorry, what case was that? 40?
We need to be careful with this negative. Make sure you have control. If not on slide, at least separate control with the batch or something.
2 cores, kind of questionable whether this should be part of the tumor tissue. Probably it is. It's not normal breast, so why not? So 2 good cores. I'm not even sure what this is, because this looks like maybe some intraductal or encystic portion or something. It seems to be a bit floating about. Okay.
Considering that it looks all the same and that portion that you look, it was definitely invasive.
Okay, so your controls are here.
Yes.
Quite satisfactory. The test tissue, we have repeated twice.
Yeah.
What happens if one is positive and the repeat is negative? What would you do?
I would take the positive one, to be honest, because if the controls are good and you have positivity in one of the cores, then you cannot disregard that one. And you would assume in the other one it didn't work.
Okay, so this one looks as if there is no staining, and I think probably with 142 you can be confident that at this level you would see staining.
Yeah.
And if you don't see staining at this level, the amount of positive cells will be so few that will not really make a difference. But yeah. Okay, so no, just for completeness, I'll look in the other one as well.
We should. We did have cases like this, and now we had a period of time, I don't know if we are still doing it, when we were putting controls up and down, both on the slide.
Yes.
To make sure that we do have proper staining on the tissue.
Yeah, so that's interesting. And, sometimes this reveals the amount of trouble each person has with this type of test. So, there has been a time where we had asked the laboratory to put 2 sets of controls because we couldn't get our head around why a test tissue would stain, but the control wouldn't stain, and vice versa. And we had problem in these things. So we thought, we'll just spread the controls around and so on. And sometimes these things happen and then they go away, and you don't really know why this happens. Obviously the machines are periodically maintained with preventive maintenance, and so maybe the little jets of air that circulate the antibody around the section are better and more efficient. Who knows? Okay, so this is part of the cookery type of immunohistochemistry. Okay, 4th case. This slight hesitation is a little bit positive. Some few people thought it was a bit positive. All the panel thought it was negative. Number 4 is case 43.
Yeah.
43 would be this one, the one above. Okay. This is, I think this may be an interesting case because this could be a lymph node. Maybe not. Is this a lymph node? No, there is a neat edge.
Yeah, and all these residual follicles,
which are maybe residual follicles.
However, tumor,
it's an interesting tumor, very apocrine. Yeah. But Simona, even if this was a lymph node originally, I think there is no significant amount of residual
Plus,
node
even
tissue.
the residual lymph nodes, they're completely surrounded. They're small residual lymph nodes, and they're completely surrounded by tumor cells. So from my point of view, any staining that we would see in this core,
you would accept.
I would take it into consideration.
And then you see here there are intervening cells, so there is an
many.
infiltrate inside. Okay, and this one is probably, I don't know, who knows what we need to say a little bit.
Remaining.
Okay, this one again controls, not so good. Look.
A little bit weaker, yeah.
Well, a little bit substantial.
And see, and if you can go up, yeah, see, up and down, exactly. And this is quite good. I mean, it's
okay. This is
better.
very good. Okay, so I have an element of doubt about this case because I understand that these tonsil stains well, but the cell lines don't stain well. I mean, if we just do a little reference to the previous case, which I think was this one here.
Yeah.
Yeah. You can see immediately that the slide above has not performed.
Yep.
Yeah.
Indeed.
So this would be a red flag to say something has gone wrong. Okay. Well, that's kind of interesting. And then we have a look at the test slide, which is test section, which is this one here. We are kind of OCD pathologists. We need to put them with the right orientation. And is, as they say, not a sausage. You're right. This may be tingible body macrophages. So these could be residual or new or like tertiary lymphoid organ if this was from the breast.
Look, I would take that into consideration.
You would?
Look, no, this area here. Yeah, definitely.
Okay, but even if you did, this would be insufficient.
Yeah.
That's
they're very, very rare.
Very rare.
Thoughts.
Okay, but what about my fundamental issue that the control at the bottom didn't work?
You can always repeat it.
This one didn't work, or this one worked.
That one worked. You can always repeat.
I would repeat this case. I would
when you have a negative tissue and the controls are not great, yes, keep in mind and repeat it. The other way around, negative controls, but positive tissue, it's okay.
Yeah, I think
you can go with it.
I think probably it's okay.
But if it's negative completely, then you do not know for sure if it works or not.
Okay, very good. Okay.
Nevertheless,
tell me.
The majority said negative. If some would have said not accessible, we could understand that.
I think so.
But I don't think this case could be positive on this.
Not as it stands.
Yes, no.
All right, yes. Okay, good. We're making good time. Fifth case. This is a little bit more controversial. 15% say positive, the rest negative, and no, this is controversial also for the panel, in inverted comma, because a third thought that this would be positive, essentially.
Yeah.
Instead, the rest of the majority thought it was negative. Okay, that's kind of interesting. And 44.
Yeah.
Okay. 2 areas. Not sure that this is invasive.
Yeah, it is.
Yes, it is invasive. Not all of it is invasive. I don't know.
This
looks to me a lobule.
Maybe not the lobule, maybe.
Okay, maybe
I think it is completely invasive.
Okay,
yeah. This, on the other hand, this is in situ wise.
In situ. And this one is also invasive. Okay, so these are here. So question for you. Is this the tumor area? Or is this the tumor area? Which one? The tumor is important, it's our denominator.
Yeah,
which one
is true?
Is this tumor?
My point of view,
yeah,
I would say no. But what I learned, let's not jump immediately. let's look at the 142. If it's negative, that this question,
It doesn't matter.
It doesn't matter. If it's positive, and depends what positivity and depends how many cells, then yes, then you're asking yourself questions. This is a thing that I was trying even before, and
you see,
quite
this
weak,
is
a little bit weaker.
And
let's
we don't have
pretend that it worked properly, and
I see. So I think again here this doesn't seem to have very much.
Can you zoom in here?
Tiny amount.
Okay, so you have a few very scattered cells and tiny as well.
Yeah. You can almost count the cells one by one there.
Yeah, 7, 8.
Yeah, the same here.
15 in total, 20 maybe in total.
Yeah, so small numbers. Okay.
Very small numbers. And another part you can do, okay, on that tumor itself with that area, would you make it 1% altogether?
Not enough.
Okay, now on this one, on the second area, which is larger.
A little bit here. But again, this is something, usually when you have to go to such high power, it means the number of cells are very small and they don't really even show up at lower power, and therefore it's kind of unlikely, much less likely that you can make it positive. It's really not. You have a lot of fields with nothing. And to be honest with you, I know I'm only at ×5 or whatever, but there is nothing, it's not as if I'm missing anything now,
So now, even if we are not taking, and that's nothing, that's from formalin or
okay. So this one would be negative to us, yeah? Or look here, this is also
nothing.
Nothing, okay.
The
same here.
Even if we are not taking into consideration that area in between the two tumors, that means the overall area, it will be less.
Okay.
And even like this,
so even if
think we have enough.
So even if we say the invasive carcinoma area is only this bit and this bit, it will still be negative. There's a question. Yes, comment.
If this case is post-therapy, it looks like post-treatment scarring. In that case, I would not count the fibrosis. I tend to exclude wide hypocellular areas, even if the patient did not have therapy. I'm not sure if correct.
Yes. Well, it's interesting comment, and I agree fundamentally, but I also can tell you nobody knows what is correct. That's the reality. But yes, I would say most of us would probably say I'm not going to include this denominator. Yeah, absolutely right. But in any case, it's too little. The amount of staining is too little. Yeah. Cool. I still think that we should be more mindful of the failure of the controls. Yeah.
Indeed.
And that's to me, this would be I would repeat for me, because you see the number 2, which should have this is a bit strong for number 2. Obviously, this is the number 1 cell line. Should have almost as much as this one.
But
it has completely nothing, or just 2 cells. So this is clearly underperforming to me. And so you don't know whether a little bit more analytical sensitivity would make that tissue more. I would doubt it, but I think, yeah. Cool. So we are on the last case. Nice. Where there is a slight indecision on whether it would be positive or negative. Everybody on the panel thought it was negative. The majority thought it was positive. This is a reversal.
Yeah.
This would be interesting to look at then. Okay.
48.
48.
8.
Oh, sorry.
Last one. Yeah.
Okay, so this is the biopsy, not a fantastically straight biopsy.
Okay. From me, I'll be very, very careful with all these necrosis.
It's a lot of necrosis.
So we should not, if we have any staining over there, we should not take that into consideration.
So if you find staining only in this very small rim of cells just by the necrosis, ask yourself the question, am I actually looking at PD-L1 positivity, or is it just an artifact of the necrosis?
Exactly, if it's real or not.
And there are a lot of these ribbons with necrosis.
Next step, identifying your areas where you have...
There's a little bit of this, a little bit of this. A little bit here. So there's quite a lot of
lymphocytes,
tumors.
yes.
But is this primary or is this a
Good
lymph
question.
node?
I have no idea. I mean, on this fragment, you only have here, you only have this bit, with tumor. The rest is completely just immune cells, completely.
Yeah.
So you have no tumor at all over there. It's metastatic. Yes.
It's metastatic. So this is a node. Okay, so that's a kind of an important information that I don't know whether we had it when we were when the participants were assessing this, because there may be different way in which you assess the tumor. So well, yes, because I think if it's a lymph node, some of us would say, I will only score the cells that are intrinsically touching tumor cells, because that was the original kind of concept of scoring lymph nodes.
Even if it's not metastatic and you do have some lymphoid follicles or some, not lymphoid follicles, but some formation of
lymphoid tissue.
Yes.
Yes.
Clusters of lymphocytes near the tumor.
Yes. So you will need.
How are you going to score those?
You will need to decide.
So exactly. I mean,
to decide.
I think it's more or less the same approach. How much are you allowing for the score? How much are you allowing the staining to be part of your score?
Yeah. But that may explain why there was such a big difference between panel and the participants.
You have staining,
You have staining where? Here,
and there,
here.
But let's look,
But that's the lymphoid tissue.
Yeah. But just here, so if we are putting times 10, here you have no tumor at all in this field.
No.
If I'm going higher, still not tumor. If I'm going now, it's my tumor. Here it's my line, where here from up, I have tumor.
Yep.
In the tumor, maybe.
1 or 2 cells, not a lot.
This, I wouldn't argue. This I would take into consideration, this little
So you
bit.
would include these few elements here?
It's
I
agree. More up and down.
But what about this one? No, this is really not.
No.
You feel okay. Again,
Necrosis.
That's
the border of the tumor, that it's exactly near the necrosis
and it does look a bit different as well, if you think about it. So this would be a bit suspicious to include. This probably is necrotic material. So no, possibly no. Here there is a little bit of staining, but again, I think this is only lymphoid cells, not tumor, so probably not.
Regarding what you said, if we would have known that this is a lymph node, yes, maybe we would be more aware. If we are seeing these clusters of lymphoid tissue, okay, do not count them if they are not surrounding by tumor per se. So.
But what if this was a primary, if this was breast tissue and there was this tertiary lymphoid tissue, would you still score it as part of the tumor, or would you say, no, this is not?
No, if I don't know, I would not. I would have the same approach if it's nothing on a field of 10, 20 usually.
Okay.
Because usually you're putting, but we were on a field of 10 and I still had nothing on that field of tumor. I'll not take it into consideration.
Some questions, or comments?
Do you think that we need to watch out for other lymphoid structures like MALT, BALT, etc. in tissue samples besides negative lymph node tissue and scoring?
Yes, and I think this was the original thought behind the warning of not scoring organized lymphoid tissue, was saying, because otherwise anything that arises in the context, for instance, of mold, etc., it will always be positive, and then it will be that. Yeah, absolutely right. Something else?
Are immune cells not counted as part of staining?
Yes.
Yes.
So the immune cells do count. This is our target. Our target are the immune cells, but the task we have is to distinguish immune cells that are there for other reasons. Classically, this point arose in the biopsies that had pre-existing lymphoid tissues, like somebody made that example of mold, for instance. That's true, or not mold, but mucosal associated lymphoid tissue, or etc. And then the other example was in bladder biopsies, if you have an ulceration.
Exactly.
That has got an infiltrate, but it's not a tumor-related infiltrate.
How we are calling it, and how it is also in the guidelines there, the the immune cells intrinsic to the carcinoma.
And also in bladder biopsy, often these bladders were treated with, say, BCG, you know, as a part of therapy. So you would have disorganized the lymphoid structure that most of them would be positive, then everything
and they would be there
positive.
anyway.
Yeah. So that was the kind of thing. They said, no, they really need to be the cells that interact with the tumor, because if you go back to the theory, and it's very much a theory of why this therapy works, is because the tumor has found a way of interfering with the cell-mediated immunity against the tumor by activating this axis of inhibition using PD-1, PD-L1. And so unless you demonstrate that these are cells that interact with the tumor, then they felt it was not identifying the right patients. So for instance, here, as Simona said, that these are, it kind of hinted of these times 20. So if you see here is 19.9, I can make it 20. There you go, 20. So, and then Agilent came up with this kind of rule that if you put the tumor in the center of the times 20 field, remember this, we're talking about microscopes, so this would have been a round thing. And then you say anything in the field of times 20 would be part of the infiltrate. So that was
That's very good advice. And especially, that's again, going back to what you said, if it's metastatic, that's more difficult, especially if it's a lymph node. You have all your lymph node, normal lymph node, and then you have a tiny bit of a part metastatic carcinoma, and they want PD-L1 over there. Of course, the lymph node is going to stand, but how much are you taking it into consideration that you're making the tumor positive or not?
But also, it's about you as a pathologist kind of getting the impression of whether there is preserved nodal tissue or whether the lymphoid infiltrate there is no longer pertinent to the lymph node. This is an infiltrate for the tumor because the tumor has replaced the normal nodal structure. The nodal is effaced, and therefore, okay, everything is game. So here there are, again, good amount of staining. So this is near tumor cells. So I could consider these, and we do our little times 20, put this in the center or somehow in the center. So this would be
that's what I'm
admissible.
Saying. Yes, but again, it's a question if all of it or not all of it.
Okay, so basically there is an element of interpretation which will make positive or negative possible, depending on the pathologist interpreting, So overall, how would you score it, and why?
I think overall, I would score it as negative.
As negative. Why? Because
you have a lot of the residual lymphoid tissue, a lot. And from my point of view, in the moment that I'm going and I'm looking at the tumor, and almost you have nothing in the tumor. So the immune cells that are within the tumor, they're not staining. That's, for me, it's a little bit of red flag that everything that is staining, they are the residual lymphoid tissues and the necrosis that is flanking the tumor.
And sorry, while you're talking, I'm doing my little game. So I'm trying to put an area which is kind of more or less like this, but I cannot see what it is. It's 800. So I need to go down to something that I cannot see.
Well, zoom a little bit,
This is 0.4. This is still too big.
Too big?
Okay, sorry.
Should be for what?
1%.
Of what, 1%?
Of that area that I
just
here. So my area 1% would be would this be something like this? So what I wanted to ask you, see, this is my 1% area of this area here. I think this would be 1%. This would be 1%. So this particular fragment would be 1%. This is not tumor here.
Exactly.
And this particular fragment could be 1%. So I have two fragments that I could give 1%.
Okay.
I think you're right. Here I lose big time because there is a lot of tumor area and there is
a little bit over there if you're and so then you have the problem is this fragment, I think, that is all tumor and you have only tiny little bit.
Not enough. So I have while this fragment and this fragment, I probably make it 1%. This one is well below 1%. This is significantly below 1%.
These ones here as well.
And these ones are not showing very much. Yes. So yeah, I agree. And these ones we said with comment on these things.
Yes, I think this is a little bit of interpretive, how you really want to.
How much you are going to attribute.
Yeah.
But you know, Simona, this is again is a touch and go diagnosis.
Yes.
I can see why some people said negative and some people said positive.
But at the same time, we could have native staining in the lymph node that just happens to be next to the metastatic carcinoma, but not relevant. I think that the point Simona is making is good because staining only at the periphery is suspicious, especially in a lymph node metastatic.
Yeah.
Metastasis.
Yeah. Okay, this is a really kind of difficult field, mostly because we don't get any assistance in how to interpret these things.
We can always, especially because it's a metastatic, and usually when we are reporting this, we are aware of the tissue, what it represents. We can always make a comment, please consider repeating on the primary.
Yeah.
And that will be even more accurate.
If there is a more obvious more obvious reply. So would you stand with less than 1%?
Yes.
This would be a case that would give me a lot of problems. I would probably ask colleagues to look at it.
Yes.
It's a difficult case.
I think it's good to ask a colleague.
So, you know, that's interesting. So this is the only one where actually most of the participants thought the other way around. And to be honest with you, I don't know in which of these two boxes I would fall. I was kind of thinking maybe I would fall in this one, but I don't know. I would be very uncertain.
Controversial cases.
Yeah.
And we do not hold the absolutely truth. I mean.
Yeah. Okay, so I think this circulation was, we can stop sharing, I guess. I think this circulation was extremely challenging. How do you stop sharing? Here it is. It was very challenging, but I think the results were very good, actually, no?
The results, yes. Yeah. But I do think we had, you closed it.
I closed it? Yeah, I can share again.
We had 2 questions at the end, I think.
Sorry.
That's
what do I need to do?
I have no idea. Yeah. And
question at the end here?
Yeah, there were. And I really wanted, okay, Gerald, should the expression be present in both cell types, tumor and inflammatory?
Okay, you can answer that.
Because it's a circulation for triple negative breast cancer. This depends on the tumor type. Always see what tumor type are we dealing with in TNBC in the breast cancer. We are taking into consideration only the immune cells that are close contact with the carcinoma, like we mentioned earlier. Yes, there is an indication also with tumor in lung. In lung, also for the use of atezolizumab, we have the assessment is both IC, immune cells, and also TC. And the thresholds are more than 10 IC and more than 50 for tumor cells.
50% TC, yes.
So both. So again, be aware. Again, 142, we have indication in urothelial carcinoma, again, where we have the threshold of immune cells 5%.
And no tumor cells.
And no tumor cells. So depends on the tumor type. Yeah. But in this indication of triple negative, we are talking only about inflammatory cells and not necrosis, because over there also is inflammation.
Indeed. Okay, very good.
Okay, that's good. Thank you for the comment.
So thank you all very much. I don't know if there are other comments that people want to make. Please unmute yourselves.
Yes.
Otherwise, we're
happy with people interpret it. Yeah. Now we don't know if, because some of them for us were tricky. We don't know if they were too easy for everyone, or there was just good concordance and people were confident, but they were still tricky.
I think it's randomly we all got it right. That's what I think it is.
That's not very helpful, or I don't know, not very nice for a patient, I think, to hear randomly.
I think you know, it's very interesting. We've been doing these things for a long time, and you know, at the beginning, and when we were doing a lot of face-to-face training, at the beginning there was an element of thinking, I think these diagnoses are random. I can't make head and tail of it. But I think as the module progresses and matures, I think we are probably understanding how to be concordant with each other. Whether this helps or not, I don't know. Yeah. Some questions here. Let me just open these. So, yeah, very good. You can read this.
It's too small. Thank you.
What percentage of cases in real life are negative in your experience?
A good question.
But no, because I no longer do any
Yeah.
diagnostic work, you know. Simona does all the diagnostic
I mean, it's difficult to say, honestly, because I'm trying just to think about the breast, and it's
Yeah.
very difficult because we are seeing everything. I mean,
Okay.
any tumor, I really don't know what to
I think
say.
in the series we published
that will be good.
was a little bit below the trial data, and then subsequently a lot of other groups published that the numbers are not as high as the trial data. We managed to increase the numbers by testing both primary, by testing a larger amount of
Yeah.
tissue. So we raise it, but I think you probably get, if you get to about a third, you're doing very
Yeah.
well in terms of identifying patients. And that's
Positive.
why
So the majority
positive,
are
yes.
negative.
And that's why we started to think about providing both assays because they are so different than, you know, 22C3 and 142 identify two really different population of patients. So you give options to oncologists if they want to use the immunocheckpoint inhibitors.
Yeah.
Yeah. Was there another question?
People.
Yeah, thank you.
Yeah.
Very good.
Thank you very much.
Well, this concludes our broadcast.
Yeah.
Next month, there will be a very interesting session on mismatch repair. My favorite.
Is it?
Yeah.
Okay.